Wonderful. Well, those are great perspectives, and tying back to some of the discussion from earlier today. I guess, Sabrina, one question I would ask is, and we have plenty of time for discussion, about 15 minutes for discussion, so please do, well, 9 minutes for discussion. Thank you, Ceci. So be thinking of questions out there. Do you think that, Sabrina, there's a, a barrier above all that needs to be focused on in the short term to get the dialogue moving, or do you think it is this list of 8 or 9 issues that we need to address simultaneously?
Well, I wish there was one magic bullet that we could hit and everything would fall into place. And this is a challenge that I ask my staff all the time. We know that reimbursement is one of those key levers, right? And the policies are barriers. Eventually, we're going to solve those problems like we've solved a lot of other problems. And the question that I pose to my staff is, okay, then what? Then what happens? Have we prepared this industry to really launch and effectively integrate telemedicine? And so that's why I think some of these issues of education, of collecting the evidence, use cases, best practices are so extremely important. Because once we do address the reimbursement area and everyone wants to get into it, we need some guardrails up. And I think quality is another area where we need to have some guardrails up. We need, at the end of the day, it's about the patient and it's about patient quality. And we have to ensure that when we roll out these programs, that the patients are getting the best quality, because there's some groups out there that may not be up to par. So we want to ensure that there is quality, and we also want to ensure that we're not increasing cost and we're getting value. So I think it's multifaceted.
I think, frankly, we should start by painting the vision for people about what this could look like. And part of the confusion around, what do you call it, digital health, e-health, m-health, that's why we came up with healthcare without walls, right? We thought that starts, now you can argue, of course, there are walls somewhere, of course, but to think about the kinds of capabilities that we have now to access care across distances, across settings, among settings, et cetera, that's the vision, I think, that if you go to policymakers and paint this, and we've done this in our Healthcare Without Walls project. So let's take a hypothetical example of a patient on Kodiak Island, Alaska, newly diagnosed with non-small cell lung cancer through the critical access hospital there. So let's say you have an extremely intelligent patient, internet savvy, figures out that the best care provided is at an East Coast major cancer center, wants to have a telehealth visit with that cancer center, wants to have his cancer genome sequenced and sent to those people on the East Coast, wants to get a targeted therapy, and basically concludes, why could not this targeted therapy be shipped to him by drone on Kodiak Island, Alaska, and infused at the local critical access hospital? Why should that patient have to get on a plane and go 3,000 miles and stay for 6 weeks to have that care when we could figure out a way to do this? And why not democratize the knowledge that is sitting there in those major cancer centers and spread it out throughout the country in this day and age? And as we've described that vision, nobody says that's a really stupid idea. They say, of course that's what we should be able to do. How do we eliminate the barriers that stand in the way of that today? And I think if we start painting that vision for people and get away from whether we call it digital health or e-health or whatever, here's what we're talking about, folks, about availing ourselves of the same things that are helping us in so many other aspects of our lives. And now how do we build the system that makes this possible, or rebuild our current system, re-engineer it in a way to make these things possible?
It's an interesting example, Susan, because it's highlighting some of the other things in the system. And actually, when you point at those types of therapies, everything underneath it, oh, well, that's nothing compared to how expensive that therapy is going to be. So you might as well just do everything the way it is. And I think one of the interesting parts of the conversation today that came through was that it's all part of a whole. There's an access to specialty care services, and then there's a basic care, primary care, population-based care, and figuring out how we tie all of this together. And I love your example saying Kodiak Island, Alaska versus, Cancer Center, Academic Health Center on the East Coast, because the first, in my mind, Sabrina, the first place people go to in the policy space around telehealth, and this is just a matter of history, is the underserved area distance place. And because there was enablement many years ago for rural areas and underserved areas, we're almost locked in this box now.
Right.
And how do we demonstrate that, people sitting 3 blocks away are as deserving of any quality improvements that happen from telehealth, whether it's in dermatology or stroke care? How do we spread that out to other
Make them
other
try to
areas?
get across Midtown New York traffic or Washington traffic, for that matter, to see how useful it
true.
could be.
No, I totally agree with you. I was just sitting here thinking of something you said that, and I really like that, with, healthcare without walls, without borders. And, so let's fast forward 10 years. Let's just say that we actually accomplished this. We really are talking about healthcare and a paradigm shift. And how do we usher and bring those along with us? And I'm going to be so bold to say this. I know that healthcare is complicated. I've been in it for 25 years and in the trenches, and I think I was like the other gentleman that says, okay, I'm tired. But this is really, really an exciting time, and I think that we overcomplicate it in so many ways. It is complicated, but we overcomplicate it. It is healthcare. And these are tools, just like we've had other tools. And for those of you that have been in it for a while, you understand what I'm talking about. And I realize that it's complicated. Reimbursement issues are complex, but we will get there, and we will have to do it systematically. It will take time, and I think that we just have to we have to work together. And I think there's a lot that we can do.
So I think we've got a couple of questions lined up, which is about the number of questions we have time for. So please go ahead.
Thank you. Daisy Smith from the American College of Physicians. I have a question about what role, we're a nonprofit membership organization. We have 152,000 internist members. And we're here today trying to learn about what you think we can do to help accelerate progress in this space.
Join our Healthcare Without Walls project, I will say self-interestedly enough, or any of the other Sabrina's projects, right? Obviously,
I would agree.
as well.
Join ATA, join one of our working groups. Either the policy working group would be a really good one, or even the education.
Because these are, as we've laid out, important, real nitty-gritty issues, and there aren't a lot of silver bullets here, but if we work together, I think we can figure it out. But it will take a coalition of the willing to move forward, especially on these policy barriers.
Hi, I'm Rohit, and among other things, I teach strategy at the University of Maryland Business School. I had a industry landscape question for you. How do you view the CVS acquisition of Aetna, and how does that change the healthcare landscape for you guys? And also, how do you view that in the context of telehealth? CVS is going to go from 1,100 minute clinics to 10,000. That is more than the number of urgent care centers you have in the United States. So brick and mortar is still there. It's going to play an interesting, different role. So how do you see the shaping up of the landscape, whether it be a vertical integration or horizontal integration? I'd like to know your thoughts.
Well, I gave it long ago thinking that there would be one universal modality for anything in the U.S. healthcare system. But it is interesting to think about the CVS-Aetna combination. And by the way, CVS is a member of ours, so they've talked about this with us as well as publicly. But it's part of what we're talking about. It's part of the movement of care out of the conventional settings. And, as they conceive of the potential, they're already looking at a lot of telehealth, from CVS Minute clinics to academic medical centers, from CVS Minute clinics to homes. And now having the store move to be something more like, as they're calling it, a healthcare hub of some sort, exactly what happens out of that hub is going to change over the decades with technology. But right now, as they say, 90% of the U.S. population lives within about 10 miles of a CVS. Right. That kind of convenient access, if I could walk into my local CVS store and sit down and have a telehealth visit with the people at Johns Hopkins, as opposed to getting stuck on I-95 for 3 hours to drive up there from Washington, we do that in a minute. And I think those are the kinds of things that they're thinking about trying to work out. And then with Aetna as the financing backbone, as Mark Bertolini has said, Aetna wants to be in the position of financing a system where having people have to go someplace for healthcare is looked at as a failure of the system, not as a success, right? Where you're addressing people, first of all, you're starting with the basis of trying to keep people from getting sick in the first place through prevention. Then, if they do get sick, you try to manage it in a setting, a home, community, office, school, whatever. And then the default, when all else fails, is that somebody actually has to go someplace. That's the way they're conceiving of their role. How do they finance a system that makes that work? So we'll see. It's a big challenge for them to pull off, but as we know, it's already causing a lot of other entities around the system to think about how they're going to innovate along the same lines.
Very interesting market forces at work.
Yep.
Absolutely. Well, I want to thank you both for very thoughtful remarks and a nice way to round out the day. So thank you.
Thank you very much. Thank you.
Murray, I think you're going to close us out here.
So with my relentless dedication to finishing on the time indicated on the agenda, I just wanted to say a couple things. First of all, thank you to our speakers, to our moderators, to the Institute for Health Policy team and the Center for Total Health team for a great event. Thank you to everyone who is in the room for your participation, your active learning here. And I would also point out, and if you can cue the slides here, our colleague Megan back in Oakland was pulling down some of the tweets. There was a very active discussion going on online, and I thank those of you who are participating there. And if you weren't live, I think you can still not violate the rules of social media by going on now and reading it and tweeting. And before too long, today's sessions will be available on our website, and you'll be notified of that. So I'll just stop there. I think it was a great day. I appreciate it. Tony, if I could have duplicated your soliloquy there, I would have done so earlier, but that was wonderful. So, and thank you to this panel again for keeping the energy alive right at the very end of the day. We really appreciate it. So thank you all, and happy holidays.